Okay, can everyone see that?
Yes.
Okay. All right, so I'm gonna go ahead and get started. Talk today is over obstructive lung disease, specifically COPD and asthma evaluation and management. I'd like for everyone to kind of like pitch in and talk too, because this can be a little dry, and so just like kind of picking the things that y'all are interested in and talking about those may be better. Just because there's a ton. Obviously, I do research in COPD, so there's a lot of stuff to know. But I'm trying to kind of hit the highlights and the things that are most applicable to people clinically. So if there's something I didn't cover that you want to know, then um, just pipe in and ask. No relevant financial disclosures. Sorry, getting a bunch of notifications. Um, so outline, I'm going to talk about asthma and COPD diagnosis, asthma management in the stable state and acute exacerbation state, COPD management in the stable and acute state, and then other considerations in COPD. So like before, going to have quite a few, or I mean, several questions throughout the duration of the talk. So just kind of pick somebody, or maybe I can pick somebody so that way kind of increases the. Anyway, so Sarah, 41-year-old secretary in an auto body shop, comes in because she's wheezing and short of breath for the past couple years. Kind of episodically, she knows that she has colds a lot. She has no allergy. She had some allergy symptoms when she was a kid. Over the past 6 months, she's had becoming more dyspneic. She's not able to keep pace with her partner while they go dancing. She smokes half a pack of cigarettes daily and has done so for 20 years. So if you were evaluating this patient like an urgent care or something like that, what would you be thinking to be the test most likely to obtain a diagnosis in this patient? Maybe just like Courtney or somebody kind of come off and talk about what you would do. I mean, it's a pretty straightforward question just to get started.
Do we have a heart rate or any vital signs on there, or is that relevant?
It's not really relevant. I mean, she's stable. She's in a basically an ambulatory setting. I just because this is a hospitalist talk. I mean, it's kind of hard to filter in ambulatory type questions to people that primarily take care of inpatients. So I was trying to think of a scenario in which you may see somebody that warrants more outpatient management.
Then I would probably go with spirometry if I'm not concerned immediately about her, deteriorating. I think that would probably be where I would head.
Yeah. So basically, kind of hallmark symptoms. She has wheeze, shortness of breath. She has some history of allergy symptoms as a child, so potentially some history of atopy. And then she has progressive dyspnea over the past 6 months, probably which is basically speaks to these asthma severity indexes, or in COPD, the MMRC, this would be MMRC2 because she can't keep up with someone her own age, which is kind of where you tip over into increased being like a B versus D in COPD. So yeah, spirometry is the right answer here. So this is our spirometry. So curve kind of the green curve is what the predicted is. So it looks like a sailboat. And then red, you see the kind of dip there as you get into the FEV1, the forced expiratory volume in 1 second. So, and the numbers are down here at the bottom, which is most of the time, which you can look at. So ratio in her post bronchodilator ratio is 70, and her FEV1 is 94% predicted, and FVC is 107. So any kind of thoughts on what the diagnosis is based off this test? So you have to look at the change in FEV1 after the administration of bronchodilator, and you have to look at the ratio and what her FEV1 is. And you obviously don't have to know the answer to this question. That's kind of the purpose of the talk, but. So yeah. You can use the chat too. I know that a lot of people were answering off the chat the last time. All these questions except for one are really answerable by chat. Yeah, so improvement with bronchodilator is really a hallmark of asthma as opposed to COPD. Um, she has some evidence of obstruction, but oftentimes spirometry can be normal. In her case, it's going to be lower because she's kind of, you know, having problems right now. But a lot of times in asthma, it can actually be normal. Um, these other problems, so COPD can look similar to this, although she would probably have a ratio less than 0.7, which hers is 0.7, and a lower FEV1, and her smoking history is kind of short to have COPD. Also, she had improvement with bronchodilator, which is more suggestive of reactive airway disease, whereas COPD is really more related to structural disease, although you can have overlap syndromes, which we won't talk about. Tracheobronchomalacia is essentially where people's airways collapse in and on themselves. It's due to cartilage breakdown and most often acidic smoking. Also, chronic steroid exposure, immunosuppression can do it. We see this pretty often actually in the hospital, but and you can also you'll see obstruction on PFTs, but no improvement with bronchodilator. And then this is not a normal test because her numbers show improvement with bronchodilator. So asthma diagnosis, spirometry is the first recommended test and evaluation of a patient with suspected asthma based on symptoms and history. So dyspnea and wheezing, characteristically worse at night. This atopy which is basically just kind of like allergy symptoms with rhinitis and rash. You have a lot of med peds people in your division, and so they're probably more familiar with this sort of thing from the peds side of it. And then criteria is increase in 12% and 200 mLs of FEV1 after bronchodilator administration. The on board exams, they like to try and get you with giving you just one or the other, but it has to be both. And they usually have a normal ratio, FEV1 to FVC ratio, rather than showing obstruction via the FEV1 to FVC ratio less than 0.7. It's often seen in younger patients, and like I've said, that it can be normal. If you have people that you think have asthma, but their spirometry is normal, or they don't show the diagnostic response to bronchodilators, or it's completely normal spirometry, then other tests that we do often, methacholine challenge is sort of what this has the highest sensitivity. So if that's negative, you can be pretty assured that somebody doesn't have asthma. And exhaled nitric oxide is becoming more in vogue, which is basically just looking at airway inflammation. And then peak flow testing is also something that's recommended, but it's kind of a weak recommendation because there's a lot of variation in peak flow testing. So in the kind of outpatient setting, not something that's done so often as much as like done for monitoring and during treatments of exacerbations and so on. And then this is a lady who's doing spirometry on the picture. So aforementioned patient was diagnosed with asthma. She was placed on albuterol MDI, which is just a regular inhaler, as needed by the provider at the urgent care. She continued to have worsening in her breathing with wheezing such that she could not tie her shoes without becoming dyspneic. She presented to the hospital and was admitted. She was treated with appropriate treatments with steroids and nebulizer treatments and improved. And then you're doing your discharge med rec. So what medication should be added to her inhaler regimen? Right now, it's just the albuterol MDI on discharge.
Chad, can you see the chat?
Yeah, I can see. I'm just waiting for more answers.
Okay, no, it's fine. I was just making sure you could.
Yeah, so overall high, most people favoring B. A, so long-acting beta agonists actually have worse outcomes in asthma as when prescribed as monotherapy, so not recommended as monotherapy in asthma. montelukast or the leukotriene antagonist. It's actually not an inhaler, so not something that could be used. And it's usually given more to people who have like allergy type symptoms. And then tiotropium or Spiriva we'll talk about, but can be used in asthma, but is usually kind of used as an adjunctive treatment after someone's on other therapies. So mometasone, which is inhaled corticosteroid, is also otherwise known as Asthma-Dex, is a treatment you could choose for this patient. So asthma treatment in the stable state. So you kind of, I mean, even recently when I took boards, if they have mild asthma, recommendation was short-acting beta agonist like albuterol for as needed use. It's actually no longer recommended by GINA, which is the asthma treatment sort of society as a sole treatment for mild asthma. They actually recommend inhaled corticosteroids for PRN use, and then they short-acting beta agonists, which used to say people like you can't use your inhaled corticosteroids as PRN, but there's some increasing data. A lot of patients kind of would come back to you and say, yeah, you can, it does work if I use it PRN. And so there's actually some data, some trials looking at this, and turns out if you use it PRN, it actually does work. So people using like fluticasone and Asthma-Dex and that sort of stuff on an as needed basis on days where they're doing worse does work, even though the formulated thought was you had to have a few days to get enough medicine in your airways to do anything. So that's the recommendation right now from GINA from like 2019. And then
quick question. So when you tell them to do it, do you tell them to just do it for like 3 days at a time, five days at a time, 7 days, and then stop, or really just like a day?
Really just daily.
Okay.
Yeah. Yeah, it's kind of weird. I mean, it's not something that it's really recently incorporated into like practice in the asthma clinic and stuff like that. And a lot of patients were doing that anyway, and just not really telling people. And so basically, and then, it turns out kind of a lot of them reported a benefit, and, everyone just thought it was kind of placebo effect, but it turns out it kind of parsed out in actual trials too. Long-acting beta agonists, I would kind of get that out of your head for asthma. That's not really something that we do as a monotherapy in asthma. Combined with inhaled corticosteroids is sometimes given, or usually we start with inhaled corticosteroids. If they're still having some trouble, we may put them on a dual inhaler like Symbicort or something like that. And then things that are used more often in asthma than in COPD are like things like leukotriene receptor agonists, so things like Singulair. This kind of work better in people who have rhinitis symptoms or other kind of atopy symptoms. And then LAMAs like Spiriva, something that we give usually as an additive to, it's supposed to be additive to LABA ICS, not LAMA ICS, but we add that on at the end there. And that's, kind of outside the scope of what a lot of times you'd be doing. But if you had somebody who was already was on Symbicort and you were convinced they had good inhaler technique and were on leukotriene agonist, if it was appropriate, or antagonist was appropriate, then adding Spiriva wouldn't be a wrong thing to do in that person. That being said, there's, not that if you're particularly interested in this topic, February of last year in the Blue Journal, which is a pulmonary journal, there was a whole issue designated to asthma. And in patients who had recurrent exacerbations, the most common reason why these patients had issues with kind of recurrent exacerbations is some sort of compliance issues. So either not taking the medicine or having critical issues with inhaler technique. So a lot of things, if someone's exacerbating frequently in the hospital, that would be something that's a low hanging fruit for you to have like RT or somebody or pharmacy sometimes come and kind of go through the inhaler technique with them. Other things to consider are spacers, which are the things that go between the inhaler and the patient's mouth, and it kind of creates a chamber for the medicine so they can inhale more, get the medicine kind of sits there, and it gives them a couple opportunities to get the medicine down in their lungs. So those two things can really improve how effective these medicines are. And there's a whole bunch of, we have these biologics in asthma now, but whether or not those are helpful because people truly have refractory asthma versus like they're kind of observed therapy and people get them every 4 weeks or 8 weeks, And, they kind of take the place of having to do inhaler once or twice a day. That seems to be increasing thought towards so Orlando asked about ipratropium, like you're talking about short-acting ipratropium, or you're talking about tiotropium?
No, I was asking about ipratropium. I heard that, before exercise or, patients with exercise-induced asthma might be useful, but I'm not entirely sure about that.
Yeah, in general, when people have exercise-induced asthma, we've just been trying to give them the ICS PRN and have them use it like the day of, or day before. We haven't been giving ipratropium as much. I'd have to review the data on exactly what the guideline is for that, but what we've been doing in practice is having them use their SABA and then using like a PRN sort of ICS treatment. And then in a setting of acute exacerbation, I'm sure a number of you have taken care of patients in acute asthma exacerbations. So you're probably familiar with sort of the treatments that can be given. So nebulizer treatments is a scheduled sort of thing, are often given. They can be the only things I sometimes see that I think can be modified on the floor when we get people who kind of decompensate on the floor is concerns about giving doing EBS too frequently and that sort of thing. Like in people that are really getting worse. I mean, sometimes, they've got one and it's been 3 hours and they think they can't get another one or something like that. And that rarely comes up, but does sometimes come up. And I mean, people do get put on continuous nebulizer treatments. I mean, that's not really a floor intervention, but I'm just saying that, you can give people nebulizer treatments if they're decompensating frequently enough to try and get them turned around. Side effects of tremulousness, tachycardia are fairly common with nebulizer treatments, especially when, obviously albuterol is more common to cause those. And if you've ever gotten one, it does make you feel kind of jittery. And then lactic acidosis, something that comes up quite a bit in the ER for ICU evaluation is because someone's having an asthma exacerbation or they're not and just got a lot of nebulizer treatments for one reason or another and their lactic acid's a little up. There's like a review on lactic acidosis in New England Journal of Medicine from like 2012 and goes through all the causes of lactic acidosis. It's a really good review, but it talks about this as a cause of lactic acidosis. Also, anecdotally, people with a lot of respiratory kind of compromise who are working real hard to breathe, they'll generate a pretty decently high lactic acidosis, even apart from getting beta blockers or beta agonists, sorry. Steroids. So we'll talk a lot about this in the COPD section. I added several slides about COPD or IV or steroid dosing and kind of exacerbations of obstructive lung disease. Sort of in general, and we'll talk, I didn't really like this to be like a journal club, but there's a lot of nuance to all this, and a lot of this is something that's hotly debated, particularly in COPD. But in general, something like 0.5 mg per kg per day daily in divided or single doses, depending upon kind of your gestalt of how sick the person is reasonable. So I usually give IV for the first day, then to try and, if they're doing better, try and transition over to PO as quickly as possible. And then in taper over 5 days is kind of like the minimum. And then if someone's in general, someone's re-exacerbated, i.e. they're being admitted because they failed outpatient exacerbation treatment, or they're being admitted to the hospital for a second time in a recent time frame for an exacerbation, then I'll taper them over a longer period than 5 days. So if it's someone's first exacerbation in a good while, I give them steroids IV for the first day, and then 5 days, about 5 to 7 days is actually the recommendation. And then if if they're coming back in for a re-exacerbation, I'll taper them over a longer period. 10 days to 14 days is reasonable. In rare circumstances, would you need to go out to longer than that? And then if they're really coming in for a repeat exacerbation, we'll talk about it. But if they're coming in for another asthma exacerbation in a short time frame, I think it's reasonable to call us to come see that person, because there's a lot of morbidity and mortality associated with re-exacerbations of asthma. So I think having us come see that person and ensure that we either get them plugged into clinic quickly or can influence their regimen or something like that is reasonable. And then in patients who are, yeah.
Oh, I'm so sorry. I thought you were at a good stopping point. I wanted to
No.
circle back around to the duo nebs really quickly.
Sure.
When I have ordered Q2 hour duo nebs for, a short period of time because someone was having a severe exacerbation. I've gotten a lot of pushback sometimes from RT about the ipratropium component being given more frequently than Q4 hours. And sometimes they want me to do albuterol only Q2 hours. Can you speak to whether that's something we need to keep pushing for, to do duo nebs every 2 hours if we need it?
No, I would just stick with albuterol actually for more frequently than every 4. You're not going to get much if any benefit from the ipratropium component, and in high doses you can actually increase like mucus secretion, and you may have seen people get like urinary retention and other issues associated with muscarinic antagonists. So I think that RT is probably right. I would drop the ipratropium component of it. I guess when I put this together, I was just saying like do an EBS kind of scheduled, and then if needed, you can increase to more frequently than that. But you're right. I think in the setting where you're having to increase on the Q2 for 6 hours or so to try and get someone turned around on the floor, I think dropping the ipratropium component, just doing albuterol makes sense and is reasonable and can avoid some issues with too much muscarinic antagonist.
Great, thanks for clarifying.
Yeah, and in that similar sort of situation where you're having to give people and kind of increase frequency of albuterol for floor decompensation or what have you, I think giving that person some IV magnesium is a reasonable thing to do at that time too. When you're increasing that neb frequency, just giving them another gram of mag, kind of irrespective of what their mag level is. I mean, it's pretty difficult to overdose somebody on IV mag. If you've ever been on the OB side, they'll run these people up to, startlingly high serum magnesium levels, and doesn't really cause much, if any, problem. So bumping them up, if they're at 2.4 and you give them 1 gram of mag, it's not going to be a huge issue for them. And then non-invasive ventilation. I know this has a lot of disposition implications in our hospital, but if someone needs it, someone needs it. So giving it to them put them on a little trial of BiPAP while you're trying to get everything turned around for a period of time is certainly a reasonable thing to do for someone you're worried about, and trying to bump them up and give them kind of I think something that I think one of the benefits of us doing these talks is us getting more familiarity with one another. And so I think, putting somebody on BiPAP and then giving them 4 hours on the floor for a period of time with some good nebs and some mag, and make sure the steroid dosing is appropriate and all that sort of stuff, can be something that can turn people around and help them out. And I think as changes happen with step down and things like that in our hospital, maybe this is something that we are able to kind of implement more often. All right, so I kind of alluded to this a little bit, but when to call us. So I think if someone's having recurrent admissions for asthma exacerbations despite adequate or maximum therapy, or even if I wouldn't even say maximum, I would say if it's something that's like reasonable, like they're supposed to be on therapy, like inhaled corticosteroids or Symbicort, and they're continuing to exacerbate, where they're coming back in the hospital and it seems like a legit asthma exacerbation, then I think calling us is definitely the right thing to do there, because like I said, there's a lot of morbidity and mortality associated with this, and quality of life stuff, and people being able to work and all those sorts of good things. So calling us to help out and get them plugged in and that sort of thing is good. And we're trying to expand our asthma clinic availability. We've added some providers there, so getting us kind of plugged into that should be low threshold for those sorts of people that re-exacerbate.
1 second.
Yeah.
Hey, Bev.
Jared was catching him up, and all of a sudden, Paul talking.
So other things whenever he calls for an exacerbation. So I would order a CBC with a diff if you haven't already gotten one kind of recently on that patient, and then an IgE level, primarily for initial phenotyping. And it's not really things that you have to implement, but in regards to candidacy for biologics and other things for phenotyping patients, it's helpful to already have that information when we see them. And then it's another person in consults for anyone who is having like kind of worsening bronchospasm, refractory to standard therapy. So that floor patient we were talking about who seems like they're getting worse, and you're having to talk about bumping their nebs and potentially putting them on BiPAP. I think, or if you're having kind of recurrent little issues like that where you did it overnight and the next morning they're not looking great and you want to see them again, or even if they are looking better, just having us come by and kind of weigh in is helpful, at least to get that person seen expeditiously as an outpatient because the chances of them having a re-exacerbation are pretty high if they're kind of having episodic bronchospasm still like that in the hospital. And then if someone has prominent eosinophilia or markedly elevated IgE with recurrent exacerbations, I would call us for that, just to make sure that we're getting that person treated appropriately. There's some things that they could have ABPA or something like that, and getting us plugged in to get that more thoroughly evaluated is a important thing to do. And then there's a lot of asthma mimics, which we see more often than you would think in our institution. Tracheobronchial malacia is fairly common, but the ones that really get you are these like vocal cord paralysis patients and those sorts of things. They look all the world like asthma, and you don't really know till you intubate them. And so, avoiding, if you feel like, someone's having recurrent exacerbations and the story seems kind of odd, or it came on later onset, or those sorts of things, or it seems to be associated with anxiety and those sorts of deals, trying to get those people evaluated with ENT or something like that is helpful. Threshold to use BiPAP is high in acute exacerbations. Not particularly, no. I think that if someone's having, increased respiratory, if they're using any sort of accessory muscles or dyspneic with kind of brief, only one or two answer word and sentences before they have to stop to breathe, I think considering a trial on BiPAP while you escalate their therapy on the floor is not, unreasonable, especially if you've already given them like a couple nebs and they're still not turning around. So, BiPAP is, acute asthma exacerbation and BiPAP is one of the pretty strong indication. So I would say the threshold is low rather than high, because we really don't want to intubate these people. You intubate these asthmatic patients, they're super hard to get off the vent sometimes. So I tend to be pretty cautious with them just for the times that I've had to take care of them when they're intubated. So brief slide on biologic therapies. This is not something you institute, but just to have like some knowledge in the back of your head about what they even are. So the ones that we frequently use, Xolair, we give a ton. That's for basically, I just think of IgE and Xolair. So those are two things I link together. And then Fasenra and Nucala are both related to eosinophilia. So they act on IL-5 and IL-5 receptor. The frequency of dosing is different between the two. Benralizumab you can give over a longer period of time. It's like every 8 weeks, I think. And then the kind of newer kid on the block is Dupixent, which is actually kind of easier to get patients to qualify for because they don't have to have the cutoffs for the eosinophilia and IgE. So if they kind of don't meet criteria for either Xolair or benralizumab or mepolizumab, then Dupixent may be an option. And like I said, basically you can maybe get away with, if they're on steroids recurrently for exacerbations, you can sometimes get people on Dupixent just off that. Theophylline is sometimes given, but is actually not recommended anymore by GINA. It's a very old treatment. If you have above the minimum dosing, you have to have check levels and so on. So not something that's given. Azithromycin has some interest in it, but is not on the mainstream for asthma treatment as much as it is COPD. But particularly in patients there's a whole bunch of endotyping of asthma that's of interest, and for patients who are so-called Th2 low or maybe more neutrophilic predominant asthma, azithromycin can be effective in those people. And then bronchoscopic treatments like bronchial thermoplasty, which is something that's offered at UAB, but has very mixed reviews in terms of its efficacy, is something that can be considered in patients with refractory asthma, particularly if they have or so-called have airway remodeling, that sort of thing at this point, because they had so many exacerbations. So this is the only question where someone would actually have to unmute their mic to answer. And it's because it's not really like an ABCD. You can certainly answer it by just putting the letters in order, but it's kind of an involved question. But I thought this is more closely approximated the situations you can put in when you're on the floor, where you can do more than one thing, but kind of getting the order of operations in a way that kind of works everything out makes sense. And there's certainly more than one answer. So 61-year-old lady admitted for respiratory failure, has sudden onset dyspnea and wheezing on the floor. She's getting Pred 40 and getting nebulizer treatments kind of as needed. At this point, she's getting better. On evaluation of patients in moderate respiratory distress, meaning using some accessory muscles of respiration. She's afebrile, heart rate's 120s, blood pressure's a little on the lower side, respiratory rate's 35, SpO2 is 91% on 4 liters. You listen to her, she's not moving great air. She has some inspiratory wheezing diffusely. So, what would be the things that you would do for this patient, maybe, and it's supposed to be in order. So maybe picking the things that you would do first to stabilize the situation, and then things that you would do kind of in order after that.
Is it okay to just enter all these orders in and sign it at the same time?
Yeah, that's an option for sure. And that kind of obviates the need to have to put them in order, I guess. But I think, functioning on the floor, for all of us who've worked on the floor, that BiPAP is not something you can get instantaneously. So I think I would probably ask for it up front, just so that it's kind of on its way, because, people have to go fetch it from the basement or wherever it comes from. And then it takes an inordinately long period of time to get it up there and get it hooked up. But in the interim, while you're waiting on that, I think, like Dr. Aiken said, giving him the nebulizer, Solumedrol, mag, kind of all together, ordering a gas, getting a BiPAP, and getting an EKG. So maybe given the treatments, if you really think this person's worse and headed the wrong direction, kind of hit him with all the things that may kind of pull them out of the nosedive right away, which is the neb, mag, which would be more acute, and then the Solumedrol, which would really hit after 30 minutes or an hour. And then having something on the way to sort of salvage that person from a potential intubation so they continue to worsen, which is the BiPAP on its way. And then really the lowest priority things are going to be the EKG and arterial blood gas. I mean, certainly valuable information to have, but I think your priority, which a lot of you would do already when we go to these MET calls in these patients, is focus on getting the situation turned around. And then, it's really immaterial what their gas is or isn't, because they're still not doing well, kind of irrespective of what the gas is. And it's always, no one know, I mean, certainly if the gas is bad, that's helpful, but the gas is normal. Sometimes I don't know what to make of that, because, they're breathing 35 times a minute, and I don't know what kind of volumes they're getting. And maybe it's not good to have a PCO2 of 42 whenever you're breathing 35 times a minute and you're blowing fast. But if it's 65 and their pH is 7.2, I think that's more clear what that looks like, what that means. But sometimes it's normal. But I think, looking at the patient, they're doing terribly. So I think, treating them like that. So it's kind of asthma. There's a lot of overlap in treatments between asthma and COPD, so we'll kind of continue to talk about similar ideas, even though we're transitioning over to the COPD side of the talk. But COPD, as opposed to asthma, symptoms are usually more general or more gradual and protracted, occurring over a longer period of time. In general, people diagnosed later on in life, characterized by irreversible destruction and post-bronchodilator spirometry, which is, we don't actually get that very often, but actually is the criteria. It has to be post-bronchodilator spirometry. And the FEV1 FVC is less than 0.7, which is often normal, which indicates obstruction, but it's, as I mentioned before, is often normal in asthma. And severity is graded by degree of obstruction using FEV1 and symptoms. That's the more recent GOLD guidelines. So they have this little box. And then you kind of grade their obstruction using FEV1, and then also use their symptoms and exacerbation history to find out where they fit in this box with A, B, C, and D. And you kind of give them a score like 2B, 2C, something along those lines. And then basically a lot of these patients have a long-term exposure to some sort of precipitant that causes parenchymal obstruction. So most often in our circumstances is tobacco smoke, but actually in the world, one of the more rising ones is biomass exposure, particularly cooking fires and air pollution. So that's increasing interest around the world. So it doesn't look like COPD is going anywhere, even though potentially smoking rates are decreasing. I guess, they were decreasing, and now a lot of people are using these vapes, and I don't know what to make of that, but so we'll see how that kind of plays into the COPD and stuff. But basically a lot of reasons to get COPD other than tobacco smoke. And then two classical phenotypes with the chronic bronchitis and emphysema, which, the pink puffers and blue bloaters. I don't really like that terminology, because I think I kind of get confused by it still, but basically one person has chronic bronchitis and one person has emphysema. And chronic bronchitis, coughing up all this tremendous amounts of sputum throughout the day, and not much evidence of emphysema on CT scan or via lung volumes. And then emphysema is sort of the opposite, where they just get a lot of kind of air trapping and shortness of breath with exertion and that sort of thing, and maybe have that sort of barrel chested appearance. both asthma and COPD are prone to episodic flares, and both of those sorts of circumstances are managed similarly with nebulizer treatment, steroids, and potentially antibiotics, which we'll talk about. So question 5, 61-year-old guy, he has chronic lymphedema, admitted for right lower extremity wound infection. Surgery was consulted for this wound and recommended debridement, asked for preoperative PFTs because he has a smoking history, which doesn't happen that often, but it does happen sometimes that they get PFTs preoperatively, and then we get asked about what to do with that. So his FVC is 84%, his FV predicted, his FV1 is 64% predicted, and his ratio is 62. He has mild shortness of breath with exertion, and his wife has to sometimes slow down for him to catch up. He's gotten evaluated by surgery. They didn't do anything, but he's about to go home. And so his wife asked if he needs any therapy for his breathing based upon what you found with the lung function testing. So what would you do for this person? Yeah, so let's see what we can see. I didn't give you his exacerbation history, but this guy would fall into 2B probably because his I mentioned earlier that his MMRC, MMRC of 2 is basically that someone can't keep up with people of their own age because of shortness of breath. And so he says that assuming his wife is similar age to him, he can't keep up with her. And so that would make him MMRC of 2. And so 2 or greater would put you in the square over here, this B side of things. And then, so he would be B, and then his obstruction was in the 60s. So that puts him, so he's 2B. And so the more recent GOLD guidelines recommend kind of treatment based off this. And so he would really meet criteria for a LAMA initiation right here. If he had an exacerbation or was admitted for an exacerbation, then starting him up higher. There's some people that do that based upon the more recent like trials and looking at trilogy and that sort of thing. So acute exacerbation, there's sort of 3 criteria that you need to keep in your head. So increased dyspnea, change in cough. So change in cough in terms of like the cough is worse, and then also change in the sputum character, either in terms of increase in the amount of sputum or change in the character of sputum. So if someone has basically with increasing number of those, that increases the odds that they're having a COPD exacerbation. And so 3 out of 3. And then one of the key elements of COPD exacerbations, as opposed to kind of anything else that's an acute deterioration, is that part of the definition is actually that you have to treat it. So that's kind of seems always like circular reasoning to me, but that falls into the definition. So that's, if that ever kind of comes up, that comes up all the time in COPD literature, that, change in therapy is part of the definition. So looking at like retrospective studies and that sort of thing that are looking at exacerbation rates, that comes up a lot. But for mild exacerbations, meaning like, outpatient, basically, like what I see when people call in and say they feel a little short of breath and wheezing a little bit more, I'll tell them to bump their nebs and do them more frequently during the day, or start doing nebs for a period of time. And main reason there, nebs as opposed to doing some other sort of inhaler therapy, it's not great behind it. The real reason is because this whole idea that people, whenever they're having an exacerbation, their inspiratory flow, like the amount of inspiratory force they can generate, is not very high because they're exacerbating. And so nebs have a very low, what we call PIFR, peak inspiratory flow rate, needed to get them inhaled. So that's why we kind of do that. And then, so that comes up sometimes when you have these really cachectic COPD people and they're just exacerbating a bunch, and they can't even inhale the powder from their inhalers. Sometimes I'll put them on nebs for that reason. But and then moderate exacerbation, nebs and steroids, and severe exacerbation, nebs, steroids, and potentially antibiotics. And then very severe, the recommendation is to give that person nebs, steroids, and antibiotics, which severe basically means anyone who's hospitalized, and very severe is someone who's intubated. So I think we would all probably err on the side of more aggressive treatment of those people. And those are sort of standard definitions. So severe is hospitalized in trials, and very severe is ICU or intubated. So this is what I alluded to a second ago. This is the new GOLD guidelines. So basically, like our gentleman we just looked at, so he would fall in this 2B range, and so he could get a LABA or a LAMA. A lot of times there's some combo medicines too that are kind of a LABA and a LAMA that sometimes get given in the situation. But in general, I mean, Spiriva is pretty cheap, and so we tend to give that as a sort of 2B situation where someone has a lot of exacerbations and they fall in this. But this is the more recent way to think about treating patients with COPD. And then if you had an exacerbation leading to a hospitalization, then that's where I told you that maybe we put them on triple therapy right up front, which would be LABA, ICS, with the goal to step down based upon kind of clinical improvement, as well as things like biomarkers like eosinophils, which is sort of becoming more in vogue now. So acute exacerbation treatment, the cornerstone of treatments being admitted to the hospital is nebulized therapy as well as steroids. In general, again, I would administer IV steroids for at least the first 24 hours, then wean to PO steroids. Antibiotics in the COPD exacerbations are somewhat controversial, but frequently utilized. Retrospective trial found that 85% of the time people are in the hospital for COPD exacerbation, they were put on some form of antibiotic, which is, I mean, pretty strikingly high. But guidance on this is actually somewhat limited. Recommendations from ATS say don't use procalcitonin or COPD to guide your decision making, even though there's been two major trials looking at this. One, the CRP one, was actually just in the New England Journal of Medicine like a year ago maybe, and but still hasn't made its way to the mainstream yet in terms of determining this. So basically, the recommendation for when to give antibiotics, people that have all three of the cardinal symptoms I mentioned earlier, patients with two cardinal symptoms, with one of them being increased sputum purulence, or patients with severe exacerbations requiring non-invasive or invasive mechanical ventilation. Those are the ones that for sure warrant antibiotic treatment. And with antibiotic, when I say antibiotics, I'm not meaning like vancomycin. I think something like a respiratory fluoroquinolone or azithromycin, like 500 the first day, then 250 for 4 days afterwards is sufficient. This isn't going to have to be like a healthcare associated pneumonia sort of thing or anything like that. But those are the summary of all the kind of guidelines right there. The first two are really more geared towards Americans, so I think I would kind of stick with those in terms of standard of care for our populations. And then I think one thing I want to bring up that we probably could do a better job hospital-wide on, including like people to get Pulm consults, is referrals to pulmonary rehab. So the data for pulmonary rehab and COPD is quite strong, actually. So it's been shown to reduce exacerbation rates. It's been shown to improve quality of life. And it's actually some systematic reviews and meta-analyses have demonstrated it actually may improve mortality as well, which would make it only the third therapy in COPD to actually improve mortality behind smoking and supplemental oxygen. So I think making sure, and the time to start pulmonary rehab is actually at the time of discharge for COPD exacerbation. So I think trying to get those patients plugged in, and you may have done it before, but there's a order that's called referral to cardiopulmonary rehab, and they're supposed to have somebody come set up with that patient and kind of get them plugged in, be it at UAB or kind of closer to home. So trying to work with that is good. We're doing some stuff with telepulmonary rehab in the setting of COVID. It's kind of expanded. Dr. Surya Bhatt, who you may or may not know, he had a really good paper in the Blue Journal last year looking at telepulmonary rehab, and it had almost equivalent outcomes to have an in-person pulmonary rehab. So as we get kind of our telehealth stuff geared up, that may be a really good option for a lot of our patients who are coming from elsewhere that may not be close to a place that does pulmonary rehab, or may have sort of an insurance status that precludes them, because at least right now it's actually not being reimbursed for. So it's all in the context of a trial and that sort of thing. So it can be a good option for some patients to get enrolled into if you think they'd really benefit from it. So as far to get into the stuff about steroids and COPD exacerbations, so steroid dosing in COPD is historically very heterogeneous. So there's broad variability in practitioners in terms of how much steroid is prescribed and for how long. There is some data to help guide these sorts of things. This is just to show that basically this is a meta-analysis looking at a number of studies, randomized clinical trials that looked at steroid dosing. So it was greater than 80 milligrams of prednisone equivalents. Some of the trials differed in using, IV methylprednisolone versus prednisolone, and as well as PO prednisone. But basically, it was greater than 80 or less than 80, and there was no difference in outcomes in terms of treatment. The primary outcome was treatment failure, rate of treatment failure. So no difference in outcomes there, and actually a trend towards lower rates of treatment failure in the people who got the lower dosing. But I think 80 milligrams of prednisone per day is probably more than we're even prescribing, most of the time in the hospital. So, and this is sort of an old study. So anyway, going on. So IV versus PO steroids. This is something that comes up a lot. This is the more frequently cited trial. Basically, no difference between IV and PO. But this trial, things I'd point out, they excluded ICU patients or patients with significant or unstable comorbid conditions, which was sort of poorly defined. And the patients were given 60 milligrams for 5 days and tapered by 5 milligrams per day after 5 days. So this kind of gets into the whole thing. These people are getting tapered, and there's some more recent trend towards not tapering people and just get them 5 days. But this trial didn't do that. And this is the trial that's most frequently cited for IV versus PO. It's one of the only prospective randomized double-blind trials. So, I guess I don't really know how to operationalize that given the kind of confounder there. Other thing that's notable with this trial, which PO is not inferior to IV, but there's nearly 60% failure rate in both groups, like in each group. So you could argue that neither treatment strategy was very effective. And that's something that comes up pretty often with this kind of trial. And the reduced trial, which is something that was popular in internal medicine circles whenever it was kind of coming about whenever I was in residency. But basically looked at 5 day versus 14 days of prednisone. The first day, all patients got IV steroids, actually. So they got Solumedrol 40 milligrams IV the first day, and then were randomized to 40 milligrams daily for 5 days to complete a 5 day or 14-day course. No taper. ICU patients were excluded, and no difference in failure rates here. So I think the way I kind of think about this is basically if someone comes in the hospital and their first exacerbation for a while, then they get 5 to 7 days of prednisone 40 with no taper, and they're discharged, which is in line with what the GOLD guidelines are. If they are re-exacerbating, then those are the patients I would give a taper to at that point for the re-exacerbation. In general, I do every 3 days. I put them at 40 milligrams, and every 3 days I taper them by 10, so that's 12 days of treatment. And then I was asked to talk about non-invasive positive pressure ventilation. This is actually, good data for use of this in COPD. Reduces exacerbation, reduces mortality, no effect on quality of life or symptoms. But those first two endpoints are pretty hard endpoints. But qualifying in the non-hospital setting is pretty difficult, and a lot of you probably experienced this. Basically, one of the more efficacious ways I've found is trying to arrange a sleep study pretty quickly after discharge, because a lot of times you have to exclude sleep apnea before they'll qualify people. This is pretty hard to find resources on this, actually, on like what actually qualifies people. But this came off the Aetna website. It was just accessed, 3 days ago, so seems like it'd be pretty recent information. But basically, they have these symptoms. They have a blood gas with a PaCO2 greater than 52, and they have this overnight sleep oximetry that demonstrates a DSAT of less than 88% on at least 2 liters of oxygen. Some people require you to show at least a 20% reduction in the PaCO2 with BiPAP or with a non-invasive ventilation method, but that wasn't mentioned on that website. So basically, and this cutoff of in the low 50s seemed to be pretty consistent between other providers, other insurance carriers. So, if once you have people in the PaCO2 range, in this sort of range, whether or not they have to have a documented reduction is depending upon their carrier, but this seemed to be pretty consistent. It was between 52 and 55. And then this sleep oximetry thing, and then this ruling out sleep apnea isn't required by all payers, but it's required by some, which is why I said that sometimes it's easier just to get somebody a sleep study quickly. And there's ways in a sleep study to backdoor people into a BiPAP as opposed to CPAP. So frequent exacerbator people, considering Daliresp, which is basically a prostaglandin inhibitor. Those are people that have the chronic bronchitis phenotype with an FEV1 less than 50. And then suppressive azithro, which I usually prescribe as 250 daily for FEV1 greater than 50 in patients who are non-smokers is where the data is. And anecdotally, it seems to help quite a bit for the people that have a lot of chronic bronchitis as well. Increases like kind of bacterial load in their airways. It also affects neutrophil issues and things, and neutrophilic inflammation. So those people that have that kind of chronic yellow sputum, which we associate with neutrophilic inflammation, may be helpful there. And then the other really popular thing, which we don't do enough of, which is coming out more and more frequent in the COPD literature, is focused on managing comorbid conditions. So common comorbid conditions in COPD population, CHF, sleep apnea, and GERD. So kind of optimizing our treatment of those conditions in these people, which is sort of the whole impetus behind the BLOCK trial, which came out, which Dr. Dransfield was first author on in New England last year. That was basically looking at managing these sorts of occult comorbidities in COPD patients because they die from comorbid conditions almost as frequently as they die from COPD. And then when to call us. So recurrent COPD exacerbations aren't improving. Sort of similar thing with this marked eosinophil or IgE thing with the idea they may have ABPA. And then anyone who has COPD, kind of weird COPD, where they're getting it when they're way younger than you think they would, or they didn't have much of a smoking history, I think getting those people plugged in is helpful. We're actually an alpha-1 antitrypsin center now, and we have a U grant for that, and we have a number of trials related to this population. So one of the main issues in this in alpha-1 antitrypsin is identifying people who have it. So, screen, and the recommendations actually, anybody who's diagnosed with COPD should be screened at least once. So you usually check a level and you check a genotype. So doing those sorts of things for those people that you see that haven't had it before in our system could help find a lot of patients who we could help. So I know it was pretty fast, but I think y'all have a meeting coming up in a couple minutes. So we can maybe revisit anything that I breezed through, or obviously feel free to kind of text or email me anytime you have a question, and we can revisit things, on a more personalized level. All right.
Yeah. I don't have
Thank
a
you all.
question, Chad. Thank you for coming. Thanks for continuing to contribute to our educational efforts for the service.
Yeah, no problem.
The relationship is great. Thanks again.
Yep. Thanks. Talk to you all later.
Thanks, Chad.